excuse that I am German and that I just can't help. I'm about to start with a very, very warm welcome to our scope meeting, the community e-meeting as it is called. And my name is Harriet Langanke. You for sure you can say Harriet once we are speaking English. And I'm the chair of EATG's combination prevention program. I'm based in Cologne. What you see behind me is the River Rhine. And I hope to welcome you in Cologne. Whenever you come here, please let me know. I'm happy to show you my place and to show you and to share my experience, which is in HIV prevention and in sexual health, because I'm a sexologist and a journalist with a special interest in sexual health. Today, I'm very happy to say hello and a warm welcome. And I have to ask back to our interpreters if I'm speaking slowly enough to follow up. I think speaking slowly is always a very good idea. And in this case, we do have English and Russian. So I'm trying to give an example in speaking slowly to give the others the time to interpret. I'm here to, oh, I'm getting a news that it's perfect. Thank you. Great. So I should not accelerate. So I'm here to welcome you on behalf of EATG, the EATG, the European AIDS Treatment Group, and together with PrEPster, AVAC, AIDS Action Europe, ECOM, we are going to give you and me myself as well very important update on what you will see on one of the next slides on the biomedical use in HIV prevention. And I think before we really start with the developments of and what is in the pipeline and what is the PrEP implementation issues, I would love to ask Rocco from the EATG office to help us with this housekeeping rules. And I see they are here already. Rocco, are you going to do this or shall I?
Please, Harriet, do it. Thank you.
So you already noticed that we are being recorded. So don't tell us any jokes except you are sure they are really funny. Please make sure that you are on mute during the presentations and use the chat to write us the comments and questions and clarifications. There's folks around to see the chats and we will not forget any of your questions or commands. When we have the Q&A session, you can raise your hand. I think most of you would know that there is a line below on your screen where you can show your hand raising, and then your little, the window with your picture comes to the very first place. And if you are experiencing any technical issues, you already heard his voice just a few seconds ago, please contact Rocco. Any questions to that? I don't think so. And my 5 minutes for saying hello and for welcoming everyone and for reminding you what is going to expect us for the next 90 minutes, I'm happy to pass on for the first presentation directly into medias res to Cindra Feuer, which I would like to pronounce Cindra Feuer because this is such a German name and it's so vivid and lively. And Cindra, you're from AVAC, as we can see here. You're going to tell us what's new and what's next in HIV prevention. And as we've learned before, I'm now giving the word over to the other side of the ocean, to Brooklyn in the United States. Cindra, welcome, and the digital stage is yours. And please unmute yourself.
I just did. Thank you. I was saying thank you so much, Harriet. It's always a pleasure to be introduced by you. And hello to everyone. I just want to give you a warm welcome and a big happy HIV Vaccine Awareness Day. We call it HVAD. Don't forget, HIV vaccines are still in research. We're still hanging in there. We've got at least one large scale study happening, and I'll talk a little bit about that today. But today is going to be mostly focused on ARV-based prevention, my presentation, because that's where a lot of the new excitement is coming from. So I hope that we're going to put in the chat some really good new information and background readings. So what I'm going to give you a whole bunch of information. It might be a lot, it might be really fast, but please look at the link that we're going to put in the chat if you're interested in more. So let me just dive into it. I don't have that much time, and just start with an overview of where we are on the globe. You know, UNAIDS puts out targets every few years, and 2020 was a milestone we were supposed to reach. They had anticipated and targeted a global HIV incidence rate of 500,000 by the year of 2020, meaning that prevention would be so good when everything was rolled out that only 500,000 people would be infected in the year of 2020. However, we didn't reach that, and 1.7 million people were infected. So what does that tell us? It tells us that the tools we have are not being rolled out to the right people at the right scale, and maybe we need some new tools, including a vaccine, including long-acting injectables. And so that's why the research pipeline is really important. Next slide, please. This will give you an overview of PrEP rollout, and this was the last quarter of 2021, so about 6 months ago. You know, again, there was a 3 million, a target by UNAIDS, they set at 3 million by 2020. And in 2021, we still hadn't reached that. We had about 2 million people on PrEP, and this map will give you an idea. And if you look closely, you can see Europe is sort of middling. Well, Western Europe's doing okay, France is doing okay. And then as you move east, there's less and less. And this is oral PrEP. And oral PrEP's been proven for 11 years, and it's still not rolled out to scale. Next slide, please. And even more difficult of a situation is that even when people do get access to oral PrEP, they don't necessarily stay on it for very long, 3 months, maybe 6 months. And maybe that's okay. Maybe they're not at risk anymore, but a lot of people do need it beyond 3 months. And this gives you just an idea that across populations, so even though this is Africa, it's Kenya, South Africa, Tanzania, even across these bars on the right, you've got female sex workers, gay men, adolescent girls and young women, people in serodiscordant relationships, all of them, their use of PrEP goes down severely by the 3rd month. So that shows you that there's an adherence problem. Maybe someone can mute their line. Thank you. It shows you that there's a problem staying on the regimen. It's an oral PrEP pill. You take it every day, or you take it around the time of sex. For whatever reason, people are not able to stay on it beyond 3 months in a lot of cases. Next slide, please. So I'm just giving you some reasons why we need a method mix, or a lot of different alternatives to just oral PrEP and the other stuff that we have. And I want to, we do have a lot of other prevention. We've got condoms, male circumcision. We have oral, what we call Truvada or TDF-FTC. We have event-driven, whether that's sometimes we call it intermittent PrEP. That's you take it before and after sex. We've got TAF, which is a very expensive, fancy form of TDF-FTC. And more of what I'm going to be talking to you in a minute is the dapivirine ring for women. And there's a dual prevention pill, which is taken every day, and it has contraception and HIV prevention. And we've got this very new, exciting cabotegravir for PrEP, which is an injectable every 2 months. And then also further down the line is oral islatravir. We'll talk about that. That's on hold. And then we've got, and the islatravir is a monthly a monthly pill. And then we've got a 6-month injectable. So you would inject it twice a year. And this is also in the pipeline. And then we've got the vaccine, which I've highlighted, and I've highlighted it for 2 reasons. The vaccine is in phase 3. It's really exciting. It's HIV Vaccine Awareness Day. And the vaccine happens to be the only clinical trial that's ongoing in Europe right now. So this vaccine is actually happening in gay men in Spain, Italy, and Poland. And then there's broadly neutralizing antibodies, which are not going to be on the market or for licensure, but they are definitely being looked at for ways for prevention, and they were actually proven to work as prevention. They've just not, you can't scale them up. So we're using them to inform science for other, for further down the line. Next slide, please. Okay, so I'm gonna focus right now on some of these, the first 3. Okay, so the vaginal ring, it was approved in 2020, and it is going to market now. It is actually in the process of being approved in regulatory. There's been WHO approval, and regulatories and bodies in Africa are in the countries where this was studied, and women are being rolled out. The next line is the long-acting, and nope, not next line. Okay, next line is long-acting injectables. As I said, we have cabotegravir long-acting injectables. We're wanting to call that PrEP, cab for PrEP. And this was proven to work in 2020, early 2021. It's been approved in the US, but no place else. ViiV is the manufacturer. ViiV is moving it for license in places where the studies took place, and the studies did not take place in Europe. So ViiV actually does have some plans in, we heard that ViiV will be going for licensing at the EMA this summer, so hopefully very soon. And then we have lenacapavir right below the cab for PrEP. Lenacapavir is it's the injectable twice a year. So it lasts for 6 months. You get 1 injection, lasts for 6 months. You go back, you get another. So 2 injections in 1 year. And it was on pause because the vial that it was being delivered in, the glass tube, was leaking into the drug, and it was not a good thing. So they put the trial on pause, and we just found out just yesterday, that the trial they have a new vial. So the trial is going to be restarted or continued, which is really good news, because can you imagine a twice a year injection? A lot of people, that could actually be a nice alternative to oral PrEP for a lot of people, if that's what they want. And then really excitingly is the dual prevention pill that I had mentioned earlier, which is the TDF FTC. So it's the PrEP pill mixed with contraception. And there's no need for clinical trials because we already know that the PrEP pill works and the contraception works. They're just doing bioequivalency. And then if you go down a little further, the purple, you've got FTAF, which is the fancy PrEP. Don't need to go into that. And then you've got islatravir. Islatravir is on hold, and this was going to be a monthly PrEP pill. Just take it once a month, 12 times a year. However, this is also on hold, and we're not quite sure that islatravir is going to make it back, because what it's doing in treatment, they were also studying this for treatment, and it turns out that it actually lowers people's T cell counts. And this is not good, especially for people who are living with HIV. And so they just put a I don't know what language it is, but kibosh. They put a stop to this trial to be continued, but probably maybe not. And then I talked about the one prevention vaccine, which is we call it Mosaic. that's happening in gay men across the globe. Next slide, please. Okay, so just really quickly, this beautiful slide gives you an idea of the last slide. Those were the efficacy trials. So those were everything that has made it to the late stage, to the large scale trials. There's a lot in preclinical and early pipeline. So there's a lot, if you look to the very right column, there's a lot of drugs being studied. There's a lot of antiretrovirals. There's a lot of other alternatives like Griffithsin, which is a seaweed, or sometimes even tobacco. So they're going to take these experimental drugs and then put them in all different delivery systems. So that other column to the left of the last one, the second to last column, those are the delivery systems. So they're going to take all these different kinds of drugs, put them in all these different delivery systems, like the vaginal ring and like a vaginal insert, or an injection, or a diaphragm, or an enema. And so if you look to the left, they're looking at this in preclinical. There's a lot in preclinical. Some of them make it to phase 1, phase 2. We already talked about the phase 3, the large ones that are about to be rolled out. And then down below, it says multi-prevention technologies. There's a lot of these there where they're taking these delivery mechanisms and they're putting in multi-purpose. So it could be anti-HIV, anti-pregnancy, and anti-other STIs. So that it prevents against pregnancy, HIV, and STIs all together in one mechanism. So these are all early phases, preclinical early phases. They're not really, we're keeping an eye on them. It's important, but it's going to be several years before we see anything coming to market. Okay, so I'm just going to get into some details of the dapivirine ring, which I told you has been approved by WHO for distribution in Africa. It's a silicone vaginal ring. Women initiate it monthly. It's inserted monthly. Men can't feel it when they're having sex with a woman who's wearing it. It's safe and effective. Its efficacy rate is not as high as oral PrEP. It hovers around 50%, but if you introduce that into a population that has very high HIV transmission rates, it can actually do some good on a population level. It's got the dapivirine ARV in it. And it is the first long-acting HIV product. Next slide. As I said, so actually, it was actually approved by the European Medicines Agency, but only for African countries. Let's see if this is relevant. And so just the main point about regulatory is that this has not been, the US said they're not going to approve it. And Europe, it has not been, the company who manufactures it, who brought it through development doesn't have any plans to ask for a license in Europe. So that is something that Europeans, if you want the dapivirine ring, there needs to be some serious applied advocacy because there's no plans for it as we speak. Next slide. And then there's the long-acting injectable cabotegravir, or CAB for PrEP. And this is the thing that is getting everyone very, very excited, including AVAC. So just to start out with, long-acting injectable cabotegravir is an ARV. There were 2 HIV prevention efficacy studies, none in Europe, but they did some in gay men and trans women, and then in African women. Currently, because they were shown to be very, very, very effective in both in all the populations, they've moved and they're currently in open label studies. So they're still looking at it to see how well it does in people who know that they're on it, who are out of the clinical trials. And it's also
Cindra, me
yes.
again. I'm so sorry to interrupt.
2
We
minutes.
are running over
Okay.
time, so we do
Okay.
hope that we can address the rest of the content and some of the questions.
Sure.
But if would it be possible to have just maybe 1 minute to kind of close
Sure.
this part? Thank you so much.
I'll close
Thank
it
you.
off. Next slide. I just want to go over, next slide. Just about some of the issues about the long-acting cabotegravir. So again, CAB was not, the clinical trials did not happen in Europe. So ViiV has not been doing much work in Europe to roll it out. Western Europe has, ViiV is price gouging. They're a pharmaceutical company. In the US, they're charging $22,000 for a year of this this injection that you get once every 8 weeks, once every 2 months. So there's got to be a lot of advocacy around prices, especially pricing in Europe. They're looking into, so this is something advocates need to watch out for. There's going to be new updated WHO guidelines on their prevention guidelines. They're going to include cabotegravir, so that's something that people can use in their own countries. HIV testing is an issue around this. You need sensitive testing enough to find, because it could lead to cabotegravir. If you're on cabotegravir for PrEP, it can cause resistance because the HIV tests don't necessarily pick up the HIV infections. That's a big issue. And there's a lot of sub-studies underway for women, pregnant women, breastfeeding women, younger people, etc. I think that's all I want to say about cabotegravir. There's so much more to know about it. Please get in touch with me. Next slide. Dual prevention pill, we don't need to get into it. I already talked about it. Next slide. Next slide. I think that's it. But next slide. Okay, and there's so many resources. We put the link in the chat, but please reach out to us. That was just a little bit of all the information that exists, and I hope it was helpful. Thank you.
Thank you very much, dear Cindra. And I think the impression that there is so much out there that 10 minutes was far too least that we gave you. It should have been much more time, but we are happy to read all the questions in the chat and to come back to what we need to discuss when we have our discussion time. But for the moment, thank you so much. And I'm very happy now to introduce to you Thijs Reyniers, as I just recently learned how to pronounce this also German family name. Welcome, Thijs. You are with the famous Institute of Tropical Medicine in Antwerp, and you are in their department of is it the public health department, I think? And you are sharing with us, as we can see on the title of your slides already popping up, the implementation challenges for the novel PrEP modalities and what we can learn from oral PrEP. And so I'm happy to listen to your presentation now. Please go ahead.
Okay, thank you very much. And first of all, I want to thank the organizers for this very terrific opportunity and great opportunity for this e-meeting. So, as mentioned, I will give a brief presentation on the implementation challenges for novel PrEP and based a little bit on what can we learn from oral PrEP. So first of all, before moving into the novel PrEP products, we also should evaluate what is the impact of oral PrEP on the HIV epidemic as it is being rolled out. And as we see in many countries where oral PrEP is being implemented, there is a reduction in the number of HIV diagnoses. However, it still remains difficult to disentangle or to evaluate to what extent this is due to the implementation of oral PrEP, especially since 2020. as this is most likely due to reduced testing and reduced sexual contact during the COVID-19 epidemic. But it remains difficult, aside of that, also remains difficult to evaluate the impact of oral PrEP, as there has been a slow uptake of oral PrEP, as has been mentioned by Cindra just before. Also because it remains difficult to know or to see whether it is actually being taken up by those who have the highest risk for acquiring HIV. And while we do have some numbers on the number of persons initiating PrEP or the PrEP uptake, we have little insights regarding its use, where it is used correctly and to what extent it is being used. So when looking into implementation challenges from a public health approach for novel PrEP products or novel HIV prevention products, these implementation challenges usually center around three aspects, and I'm going to present them here a little bit. So first of all, we have the users or the potential users. Who is most likely, who could benefit most from these products, and how can they be reached? On the other hand, we also have delivery. So how and where can it be most optimally provided? And on the other hand, how can we monitor and evaluate it so that we can optimize its rollout? So what I will do is I will focus on these three aspects, and I will focus on specific tensions between what we have learned from oral PrEP implementation on the one hand, and on the other hand, how this can be contradict or can be seemingly contradiction to challenges for implementing novel PrEP modalities. And some of these documents that I acknowledge here are worthwhile also taking a look at, and some of them have also been mentioned by Cindra right before. So first I will look into the users, and as you may know, in many countries where PrEP is implemented or rolled out or is available, eligibility criteria are used, which are based on risk. For example, being an MSM who has had condomless anal intercourse with at least 2 partners in the last 6 months. But this also presents difficulties. For example, HIV risk is variable. It depends on the changing patterns of sexual behavior. For example, if someone stops having sex, he is no longer at risk, or when somebody starts having more sex, he becomes at risk. Also, it might be more encouraging to say that PrEP is for those who want to protect themselves against HIV rather than for those who are at risk for HIV infection. And it also, what about those who are not yet at risk but want to take precautions proactively? So this presents difficulties. Secondly, when targeting specific populations or certain populations, this may increase stigma. For example, PrEP is being associated with homosexuality, promiscuity, HIV, and this can be a barrier for uptake. So one of the lessons learned is when we target PrEP for certain populations at risk, this may increase stigma, and this can be an important barrier for uptake. But on the other hand, from a public health approach, we need to ask ourselves, do we want product replacement or do we want increased net coverage? And a good example here is a study from Martin Holt and his colleagues in Australia, where they did surveys in MSM communities on different years. And based on these data, for example, based on these surveys, they found that after PrEP was introduced, there was an increase in the proportion of those who had used PrEP while being HIV negative and having condomless anal intercourse. But on the other hand, there was a decrease in the proportion of consistent condom use. Well, at the same time, those having condomless anal intercourse, being HIV negative and not on PrEP, being the red and the orange bits, these actually remained kind of stable, meaning that after PrEP was introduced on a community level, it seems that PrEP has been replacing condoms mostly. So on the other hand, it could be said that eligibility criteria and targeting populations may be needed because they help maximize the impact of novel interventions on the epidemic, because that is what we want actually. If it increases the impact, it can also increase the cost effectiveness. So it can be more likely, or it can be, this can be important for policy institutions to decide whether or not to reimburse it. And it can help to identify as a potential user when somebody sees a profile that he or she can identify with, it can lead to increased uptake on the other hand. So this is a challenge now, considering what we have learned from oral PrEP. On the other hand, targeting novel modalities to highest risk profiles may be needed to maximize its impact and the cost effectiveness of these novel tools that are coming. When we look at delivery, the majority of all PrEP delivery in Europe is currently clinic-based. But on the other hand, we also see an increased need for differentiated PrEP delivery, meaning for other PrEP delivery strategies or approaches or sites. For example, to cope with the increasing demand of PrEP users, because there will be more. The number of PrEP users is increasing, and clinics are not always to cope with the increasing demand. On the other hand, if we have sites and strategies that are tailored to the different needs of different users, it can improve uptake and retention in care, because as Cindra also mentioned, both uptake and retention in care remain to be a problem. And it can simplify follow-up, which will be more and more important in the future. So nowadays we see different approaches, new strategies, like for example, community-led or peer-led, for example, community-based dispensing of PrEP. Or for example, during the COVID pandemic, there was more focus on telemedicine or mobile health options for doing consultations online, for example. And there is more and more research going on towards decentralized options. For example, how can we include general practitioners or family physicians in the delivery of PrEP? So one of the lessons learned is the diversification and the expansion of PrEP delivery can be important to improve uptake and retention. But on the other hand, and as I will show here, there is the HPTN, I'm going to give an example, is the HPTN 83 study, which was one of these studies, as Cindra mentioned, on cabotegravir, injectable PrEP, which was among 4,500 MSM in total. I'm not going to go into the details here, but I will just briefly show you that during the trial phase, there were more HIV infections in the group TDF-FTC, which is oral PrEP, and only 14 in the Kaplan group, which is injectable PrEP. And during the unblinded phase, which was before they were going into the open label extensions, this was more or less the same. So in total, the injectable PrEP remained to be more effective, meaning that that there was a 66% reduced risk compared to oral PrEP. But on the other hand, there were still 25 HIV infections, and 7 of these 25 HIV infections in the cabotegravir, in the injectable PrEP group, were considered breakthrough infections, meaning this presents difficulties in the sense that, as Cindra mentioned, we need more sensitive HIV testing to find these HIV infections, and also there is an increased risk for drug resistance. So when introducing new tools, such as, for example, injectable PrEP, these novel AR antiretroviral-based products, they may require more specialized follow-up and laboratory testing, meaning that we are most likely to start again within the clinics. Looking to monitoring and evaluation, regarding oral PrEP, we have learned that the data collection can be burdensome for both users and providers. And also we see, and we tend to notice that there is a difficulty to monitor oral PrEP adherence and persistence, meaning also because of the changing risk of HIV. So one of the lessons learned is here, there is a need for simplifying the assessment of PrEP impact on the HIV epidemic. However, if we look at novel PrEP modalities, there is still a need to determine the impact. How can we, considering this lesson learned, how can we then determine the impact of these novel tools, and how, when we learn what the impact is, how can we improve the implementation and rollout? This will be very crucial to know what the net impact is. So the challenge will be, on the other hand, if we want to know whether these novel tools work, we will need close monitoring and enhanced evaluation methods to improve implementation and rollout. So in short, I will be wrapping up. The future of PrEP is how can we maximize current and future potential? First of all, so we, as Cindra has shown you, there are no tools coming up. These are promising times for HIV prevention. Novel, more options means it will be most likely responding to different needs of different people, which is a good thing. There is renewed energy for HIV prevention, as has been shown by oral PrEP. There is a lot more energy now in HIV prevention again. And together, all of these products have the potential to further reduce the number of HIV infections. But will it be enough from a public health perspective? I still wonder, and I still see that there is no yet silver bullet that will tackle all of the HIV infections. We still need to understand how we can reach the highest fruits, those who are less likely to be reached, less likely to take up these novel tools or to remain in care. And I think we all need to still be thinking, how can we maximize what we already have, like oral PrEP, for example. So thank you for your attention.
Thank you so much, Thijs, and lots of kudos to what you have presented from Antwerp. Okay, so I'm very proud to try out the ECHO with Luca. And Luca, if you just told us that you're not sitting next to the Scottish Bridge you're displaying here, but you're back to Brussels. And you're speaking on behalf of the sex workers' perspective, is that right? And yes. I'm very happy to hand over to you to share with us the next 6-7 minutes, please.
Yes, thank you very much. I hope there is no echo. Can you hear me properly?
Properly, very good, very good.
Hi, my name is Luca. I'm a sex worker and I'm a member operations officer at the European Sex Workers' Rights Alliance. We're a network of 100 organizations providing services in Europe and Central Asia. And we are sex worker led with a majority of sex workers on our board and in our team. And I'll briefly talk about sex workers' access to PrEP and some of the issues we are facing. I apologize, I don't have a presentation. I'm just back from a rare holiday and I will just briefly talk, but I can send some links by email as well. So the main issue is that we lack data and information on access to PrEP for sex workers in Europe and globally. So generally, that's the issue in relation to HIV more generally, like data is usually flawed or missing, and there is very little information that gives a clear picture of the situation for sex workers on HIV generally and access to PrEP. We know that there's been like specific research done, in particular, for example, in Mexico with male sex workers and in India with female sex workers. I'll talk a bit about this and some of the lessons learned. I wanted to point to one consultation that was developed by our global network, NSWP, the Global Network of Sex Work Projects. It was a consultation done in 2016 for sex workers on access to PrEP in particular. And the consultation was very interesting because it looked at 10 countries. So the global network worked with regional consultant and national consultant and did a research, this consultation with 379 sex workers in 10 countries. And the main issue that sex workers were reporting is the lack of information about PrEP. So the briefing paper from NSWP is from 2016, so things have changed since then, obviously. But one of the main issues was that sex workers didn't have enough information about PrEP and had some fears and concerns about PrEP that might be justified or might not be justified, but that were really like due to the lack of information. Like so many sex workers do want to have access to PrEP, but in many countries, it's simply not a possibility. Either there is no PrEP available or sex workers face specific barrier for access to PrEP. In our region in particular, the main issue is that many sex workers are migrants and undocumented migrants and are therefore not able to access PrEP. So I'm based in Belgium now, and if we look at the male and trans sex workers in Belgium, there is the possibility to access PrEP if you have a mutuelle, for example. And if you are from another country in Europe and you are working in Belgium, you might be able to do so, but you need to go through quite a lot of bureaucratic loops to be able to access it, which is really like a prevention for sex workers, in particular for the most vulnerable and precarious sex workers. One thing I wanted to mention is this interesting study that was done in India with two collective of sex workers, DMSC and Ashodaya. DMSC is a collective of sex workers based in Kolkata that brings together 60,000 female sex workers working in the big red light district of Kolkata. And Ashodaya are based in Mysore and bring together 8,000 sex workers. And I think this is the largest research that's been done on female sex workers and PrEP. And I think approximately 1,325 female sex workers were given PrEP over a period of 16 months, I think. And there was really high level of adherence, and no HIV infection were reported during that that trial. But I think what was the most important of this research is that, and it's one of the main conclusion of this research, is that this was a successful trial because the research, the trial and the project was done in close participation with sex worker-led organization, with DMSC and Ashodaya in these two cities. And these are organizations who have, like, you know, decades of organizing with sex workers, who have the trust of the community. And that was the main recommendation, is that for any project such as the implementation of PrEP or access to PrEP and other form of like a biomedical intervention, it is very critical to work in partnership with sex worker-led organization and communities. And sadly, we actually see in Europe a trend in the opposite direction. We know that more and more there is attempt to criminalize sex work, in particular through the Swedish model of criminalization of clients, that funding for sex worker-led organization is diminishing or disappearing, and that in many cases, sex workers are not only seen as, not necessary to be included in this type of services, but actually concretely and practically rejected and excluded from decision and policy making. So one of the key issues as well is that although for some male and some trans sex workers, it is now possible to access PrEP, usually through other organizations that provides to LGBT community. For female sex workers, it's still very difficult, and most of the cases not possible. And finally, one of the main concerns, I think, from the community is that while majority of sex workers who want to access PrEP should have access to it, and it should be done in partnership with community, we also have this really important concern that this focus on biomedical intervention is actually taking the place of looking at other factors which are actually really important in sex workers' vulnerability to HIV. And these are factors such as poverty, housing, and criminalization. And I think it's really important when we look at how to include sex workers in this project and in this new tools, that we don't replace the actual needs and demands of the communities. To really listen to the communities, like, yes, sex workers should have access to PrEP, but this should not replace looking at wider social and structural factors that impact sex workers' vulnerability. And this is particularly important when we look at criminalization of sex work. So that was very brief. I hope that's helpful. I'm happy to send an email with like some of the links to the research that I was mentioning. And that's all for me. Thank you very much.
Thank you, Luca. You can see some hands clapping, and if we were in real life, you would also hear us. And I'm now wondering if, and thank you in advance for sharing all the links with us. And while I'm getting lots of praisal for Luca's information, I'm also getting information that we still have some sound issues. As long as we cannot change it, I would suggest, and if Will just gives me a nod or a thumb up that I continue here, thank you so much, then I would like to go back to Anne and check out whether your echo issues have disappeared, and then we would go from this ESWA, the Sex Workers Alliance, to GOSHH again, to Ireland. And give us a try with your voice.
Can you hear me now? Am I still echoing?
No echo, brilliant sound, fantastic. And I hope it goes through all over other microphones and headphones. The floor is yours. Thanks.
Thank you. Hi, everyone. My name is Anne. I work for an organization and it's called GOSHH. I'm just going to give you a small little synopsis of our organization. We are a community-based organization. We are in the Midwest region of Ireland, and our offices are in Limerick. So GOSHH stands for Gender Orientation, Sexual Health and HIV, just like the name. My involvement in the whole thing is the HIV part. So I do community HIV testing, I do community HIV information dissemination and outreach. I will have to read out our vision, which is what we do. It's to create an environment where the mental, emotional, physical, and social well-being of everyone is promoted and sexual rights are respected, protected, and fulfilled. Within the areas of gender orientation, sexual health, and HIV, we actively challenge inequality and stigma on a daily basis. We believe everybody has the right to be safe and free from discrimination and violence. GOSHH is committed to health promotion and community development. I am going to talk today about the HIV care and prevention intervention in community settings in the Midwest of Ireland. And we have 3 areas, which is the Limerick city, Clare, and Tipperary. First of all, start with statistics. These are just statistics for from our office. These are the rapid testing HIV, syphilis, and hepatitis C. What I've done is I've taken statistics from 2019 compared to 2021, and I think it's all because of COVID. So in 2019, we were really on a marathon. We were everywhere doing testing, doing information dissemination, outreach, distributing condoms and all. And if you can see, in 2019, we got to do tests for 473, whilst it was half down in 2021, and all because of COVID. And in 2019, those that were HIV positive, in the testing that we were doing, the outreach testing, was only 4 people that tested positive. And in 2021, it was only 1 tested positive. And in 2021, it was because our offices were operating 1 day a week for testing. So it was only booking event. If a person doesn't book an appointment, then we were not able to give, we were not able to offer them any testing because of, you know, the restrictions and all that. At the same time, the clinic also was not fully in operation. So what we were doing is we would liaise with the clinic when they were open. Sometimes they would open on a Tuesday, and sometimes they'll be open on a Thursday, whereby we had a Wednesday set for the testings. And most of the times we were so anxious if positive result would turn up on a Monday or on a Tuesday, because then they will have to wait to go to the clinic on a Thursday. We do referrals to the clinic as well. And in 2021, we referred 67 people to the clinic, and with different, most of them would be worrying about the STIs, and some of them would be wanting to get on PrEP. This is the geographic statistics, 2019 to 2022. As you can see, in 2019, we would have had about 200, and so the highest uptake of our testing would be Irish community, seconded by the African community population. And then we also saw an influx of people coming from the North America. Our HIV care, this would be some of the challenges that we faced before, during, and after COVID. I've started with the no privacy because I want to talk about the cabinet that I have put on the other side. With the challenge with the no privacy, this is mainly talking about people who live in direct provision. Here in Ireland, asylum seekers are placed in direct provisions, which are like hostels, and they share accommodation. So there could be 2 or 3 people in one room, and they would be sharing maybe the cabinet, they would be sharing the space, or 3 sharing one space. So what was happening is that before COVID, during COVID and after COVID, still there's no privacy because they haven't been able to, they're still deciding at the parliament level and or the higher places about how to deal with the asylum seekers, whether they should house them outside or not. And at the moment, housing is very, very, very scarce here in Ireland. So with the cabinet, if you look here at the bottom, you will see that that's the HIV medication. So someone had to actually pop their medication and put them in a plastic where nobody would tell whether the HIV medication or not. And in this blue container, this is a small little container where you would find lipstick and lip glosses and all that. They would remove all that and put their medication. And I did speak to a few women who say that they are not feeling comfortable taking their medication while their friends were there because they haven't told their friends or their roommates. So instead, they would pop their medication and put them in chewing gum box, the one that you can see there, so that it's disguised. Nobody knows that there's medication in there. When they open the cabinet, they'll think that, well, that's chewing gum. I did mention though that one of them would like to have, a bite of chewing gum. What do you do when, someone takes your box of chewing gum and says, no, I'll just dive onto the box and say, no, that's not for you, that's for me. If you want chewing gum, I have, because contamination and all that, so don't touch that. That was one of the things that they were doing. Appointments were disrupted quite a lot because direct provisions or asylum seeker residentials, most of them are on the outskirts, and most of the residents, they don't have transportation to get to town. And because of stigma, a lot of people don't disclose about their status, especially people that are coming from Africa. In Ireland here, asylum seekers who are living with HIV, or people that African people who are living with HIV in Ireland, they are kind of like on the low. I always say that they are silent, they're invisible.
Sorry, Anne, just to interrupt, we're running a bit out of time. Would it be possible to wrap this up in the next 60 seconds? If people had questions in the chat or during the Q&A, we can address those. Thank you.
Okay, no problem. So the solution was treatment continuity and integrated support in mental health, fundraising, monitoring, advocacy, and communication. Catching up after COVID, our preventions, we would sometimes set up testing centers or stations outside our office, whereby people would feel comfortable in coming, because our offices are incorporated. We have LGBT. So some people like from African community wouldn't want to associate or wouldn't want to come into the services because they don't want to be seen as if they are part of the LGBT, or because of our culture, or because of African culture. There was lack of equal access to prevention information, those limited resources to HIV prevention, disruption of testing during COVID, as I mentioned. The demand for testing was very high. Access to PrEP was stopped because there was no enough manpower in the hospitals. So for all new people that wanted to access PrEP, it wasn't possible for them. They've just started now, but it wasn't at all possible. These are some of the solutions. What I'll do is I'll share the, I'll let the office share the slides.
Yes, and thank you.
Yeah, and these are just some of the pictures or set up so far. What we do, we have Pride Parade, where we set up our testing campaigns. We go to universities where if it's Valentine.
And you know you had 50 seconds. You are.
Okay.
Just let the pictures run through and
pictures run through. Yeah. Okay. Thank you.
So I can say thank you for the views from the very west of Europe, from Ireland. And you can see that there is applause in the chat and on screen for your presentation. And I feel sorry about having to cut you, but
no problem.
I'm so curious to learn from our next speaker about the completely different region in Europe, the EECA region, Eastern Europe and Central Asia region. And I'm very happy to introduce to you Nikolay Lunchenkov from ECOM, the Eurasian Coalition on Health Rights, Gender and Sexual Diversity. And Nico, you are ready to start and take your 6 minutes?
Sure, my pleasure. I'll be trying very sufficient and fast. So.
Not too fast. Please believe there are still interpretations going on.
Sure. Thanks a lot, Harriet, for introduction, and thanks everybody for listening and coming today. So warm welcome from Munich. So as Harriet said, we're moving from west to the east, specifically to Eastern Europe and Central Asian region. I'm going to share my screen. So once you see it, please let me know. Does it work? Can you see me?
Yes, it works. And I think someone has their sound on, and a goat has entered the chat. So if our participants could please put yourself on mute. And
that definitely gives us a country vibe. So yeah, so basically I'm gonna try to tell about what we see from the community perspective on PrEP programs in Eastern Europe and Central Asia. And if we would meet half a year ago, I would say that unfortunately, not all of Eastern European and Central Asian countries have access to PrEP. However, nowadays, most of the countries, apart of probably Uzbekistan, started PrEP at a certain level, even though for smaller populations, less than 100, but still we see already some projects initiated, which also gives us a kind of hope that the number of participants will increase. However, as you can also imagine, that most of the programs targeting, all of the programs targeting men who have sex with men, which remains another barrier and challenge that we always discuss, that it's a privilege of gays, cisgender gay men, and we see less other key populations involved into PrEP. So, of course, despite this horrible war in Ukraine, Ukraine remains the most successful country in implementing PrEP on the government level. We saw on the from Cindra's slide that there are quite a lot of people taking it, and I'm going back to talk about this a little bit later. So we, at the same time that we have several projects, PrEP projects started in countries, we still observe the lack of knowledge exchange between them. So even though they will work trying to work close to each other, still sometimes you see that the best practices are not so easy delivered to certain projects or organizations. And another big issue that the most of these programs are not state funded, so they're not included into the governmental budget. So and based mainly on donors funding. So of course there is still a huge stigma around PrEP, both among medical community and LGBT community itself. So that's why we're trying also to tackle during our work. And what I'm very proud of our region, even though we have lots of challenges, we still have a lot of innovative and unique methods for PrEP distributions, and as well as how to combine PrEP with other services. So, and just a few words what we do during the last 2 years. We did quite a lot for PrEP, but I'm not going to talk about all of the activities rather than just to cover 3 of them. So recently we established a resource center for PrEP in Central Asia. Basically, it's like a partnership of organizations working in Central Asia to provide PrEP in order to establish and support knowledge exchange between organizations within the sub-region, within Central Asia, because there are some differences in terms of funding, like the projects, programs, and so on. So we decided to go a little bit narrow to and focus on Central Asia region and work within it. So, and also we're trying to kind of use the best experiences and best practices implemented on several countries to share them and see what lessons can be learned from each other. So we're trying to support and participate in this knowledge exchange. So, and this is the picture from one event happened in April. We brought colleagues from Kyrgyzstan to Kazakhstan and showed them how PrEP program established in Almaty, which is, like, in my opinion, is absolutely fantastic piece of work that people do there. So the second one would be we discussed a lot about how COVID changed our perspective on providing services, and that's we forced to move lots of our services online. So for that purpose, we established an educational platform, which you can find on our website, where we have several courses covering different topics. And one of them is how actually utilize digital platforms in order to provide PrEP services for key populations. And at the same time, we developed a technical guide. So for utilize online technologies for effective counseling on PrEP. Of course, this document can be used also for providing other services beside of PrEP, because it's like very much similar, but still. And last but not least, I would like to highlight that PrEP programs and PrEP communities remain a huge source of absolutely fantastic data to better understand our health disparities and issues that people face. Therefore, last year, we initiated a study, it's called Sex, Love, and PrEP during the COVID-19. This study was initiated in Ukraine with our beautiful partners, Alliance for Public Health and Alliance Global, and with support, scientific support from Technical University of Munich. During the very short time frame, we recruited about 1,300 participants into this study. So we assessed the substance use behavior, mental health changes, and also was very new for us, and I haven't seen much data on this topic, was intimate partner violence, which was now being conceptualized and discussed widely within the community. So we finished the data collection just 3 days before the war, and like of course we're trying at this stage, we're trying to think how we can use this collected information to support our partners, how we can show the commitment to Ukrainian organizations that we want to support them, and so on. And what was also interesting that we identified in this study that a part of the issues towards substance use behavior, mental health issues, and so on, we identified that the dropout of PrEP was extremely low among people who were taking PrEP, means that like a system that was established in Ukraine is like highly effective. So even though when like in other countries, people were stopping taking PrEP, lots of people still kept on PrEP in this country. And as you see, what was pretty shocking for us, apart seeing mental health symptoms, we also identified very high prevalence of IPV among men who have sex with men. Of course, it's just the first findings and preliminary results, but it definitely gives us a certain layer of things that we might want to discover by using services. So by showing this data, I want to say, like, we always need to keep in mind the information that PrEP is just the door for services, as well as the door to better understand our health and well-being, and of course to talk about issues, social issues, and so on. I'm gonna pause here myself. So here's my email and Twitter. So thanks a lot for your for listening to me. And yeah, I think I'm done. Thank you. Thank you so much, dear Nico, for sharing with us your views from the EECA region and from Ukraine especially. And we all look with a very certain attitude to your country at the moment.
And I'm now very pleased to say thanks to all the presenters, to all the speakers. And it's a great pleasure now for me to hand over for the Q&A session and all the questions to my dear colleague and beloved friend, Will Nutland. Will, please, it's yours now.
Thank you so much, Harriet. It's great to see so many friends and colleagues from around the world. I especially want to send love and solidarity to everyone in Ukraine and all of those people who have moved out of Ukraine. You have our love, you have our solidarity, and everything that we can do to support you. You know we are here for you. I'm Will Nutland. I'm the co-founder of PrEPster. I'm also an honorary assistant professor at the London School of Hygiene and Tropical Medicine. That explains the weird background. I'm currently in the bowels of the building in Keppel Street in someone else's office. And I'm also a PrEP user and one of the founders of the international network of people using PrEP. I have my PrEP Works, my PrEPster PrEP Works t-shirt on in about 15 different languages. If you want to grab one of those t-shirts, drop me an email. I'll really happily send you one. So I've been tasked with trying to fire some questions and comments and then to try and summarize today's discussion. And of course, as always, we are massively out of time. So the challenge is going to be to cram what should have been 45 minutes into about 16 minutes. So I actually want to start with, go back to Nikolay. And Nikolay, I've got a question that I want to ask for you, if that's okay, to start the conversation going. Nikolay, in your really engaging presentation there, you've told us about how organizations and countries in Ukraine have been able to share knowledge and share ideas. You just told us about some of the events and activities. I think, Ukraine has a lot to offer the world. And by the way, Ukraine, congratulations on your Eurovision win. Nikolay, what can Central and Eastern Europe offer? What are your top tips that you can offer Western Europe about oral PrEP implementation? Because I think in some instances, Eastern Europe are head and shoulders above PrEP implementation than many other parts of Western Europe. What can you tell us? Your 2 or 3 top tips in the very limited time that we have.
Sure, thanks a lot. Well, as a PrEP user in Western Europe, here in Germany, I can say that what is really missing is the digitalization of services. So I would love to see more engagement of technologies into PrEP services. So either both supporting the adherence or promoting PrEP. The second thing would be definitely minimizing the medical participation, like medical doctors' participation in PrEP delivery. So we know that PrEP, it's not that complicated to provide and can be easily done by community workers. So maybe to land PrEP on the community level would be fantastic. And also probably the third, yeah, and maybe to do more promotion towards PrEP on specific population, so and include more other communities into that. So
great, thank you, Nikolay. And I'm gonna go to Thijs, because actually, Nikolay, you've just mentioned something that was kind of reflects on Thijs's presentation. Thijs, I'm someone who uses oral daily PrEP. And since COVID started in London, my clinic is just around the corner, the Mortimer Market Centre. Pre-COVID, I used to have to go into that clinic 4 times a year and always see a healthcare professional and go and get my 3 months worth of PrEP 4 times a year. Post-COVID, I now need to go physically into that clinic once a year. And most of my PrEP use is done by telemedicine, by video. My PrEP is mailed to me, and I'm reducing the amount of time that I have to go into the clinic. That makes me very happy. It makes the clinic staff very happy. The challenge we're now starting to face is, as we advocate for new technologies of PrEP, let's look at injectable PrEP. Injectable PrEP, if it gets licensed and the NHS approve it, if I move to injectable PrEP, I'm probably going to have to go to the clinic around the corner at least 6 times a year, if not in my first year 7 times. what's the challenge? How do we kind of balance that we're moving away from clinic access of PrEP on one hand, yet some of these emerging technologies are actually going to put greater pressure on clinical services? How are we going to find that balance?
Well, as you mentioned, and that's the difficulty of the balance right now. And we in Belgium too, for example, we're now looking into possibilities for decentralizing or looking for collaborations with other health professionals and the clinics to get the increased demand is huge in Belgium. There are even waiting lines for those who want to start with oral PrEP right now. So how can we, and this will only increase because there will be an increasing demand for oral PrEP. And with injectable PrEP, as you said, this is now 8 weekly instead of, for example, 12 weekly. So this is most likely to put an increased burden on these clinics. So how do we balance this? I think we must look for simplification already and try to take this lesson learned from oral PrEP and try to, from the start, to see how we can implement injectable PrEP, not only in the clinic, or to look for collaborations. For example, if there would be an option that there would be home nurses that drive around to give the injections, just to give an example, or to include the family physicians or general practitioners who can from time to time give some of the injections, maybe not all of them. But I think in the first phase, it will be more interesting to look for collaborations between the clinics and other health professionals, or to have simplified visits where people just come in, have an injections, and go out again.
Thank you. It's a kind of innovation and collaboration, and I'm reminded of a project that happened in East London a couple of years ago, which was called Luba, where people went around on bicycles and delivered condoms and lube to people who wanted them. So I love this idea of maybe nurses going around on little bicycles, injecting people who need PrEP. I'm actually I want to take the conversation, and Gus, thank you for your comment, your question. We'll come back to that in just a second in the chat, but I want to go to Luca. Because Luca, one of your central comments was around decriminalization, fighting the criminalization that many sex workers face, including sex workers who are migrants. I'm very proud as an organization, the Love Tank, which is PrEPster's parent company, that we have been an organization that has understood the issues around sex worker criminalization, and we've been proud to work in solidarity with some of our colleagues in the UK around that. But some of the organizations here today won't necessarily understand that we have a role in PrEP advocacy to also be fighting for human rights, and particularly the human rights of sex workers. For those organizations, what should they be doing to make sure that we can support sex workers, particularly around criminalization?
Yes, thanks, Will. I think it's really critical for HIV organization or public health organization to work closely with sex worker-led organization. And in countries where there is no sex worker organization, I think it's also the role of HIV or health organization to support the self-organization of sex workers. So we work closely with, for example, Carousel in Romania to support the organization of sex workers there, and as well with like GATT in Portugal. And sometimes all you need to do is organize a space for sex workers to come together and understand that their issue, their individual issue are actually like political and community issues, and then work hand in hand with these individual sex workers and organization. And I think we really need to be aware of the impact of the criminalization that's taking place in Europe. And fortunately, I think we are starting to see a trend towards decriminalization now. There's more and more evidence that's coming about the impact of the Swedish model of criminalization of clients. I'm based in Belgium, where sex work was decriminalized a few weeks or a couple of months ago now, thanks to the leadership of sex workers and their organization. And there's more and more evidence of the impact and of decriminalization. And I think it's important to really, at both organizational level, but also individual level, to really hold people accountable when they are supporting criminalization of clients. In particular, for us who belong to the LGBT or feminist movement, to really bring this issue when it comes up, not to be afraid to call out people when they say like, oh, prostitution is a form of violence, we need to abolish it, and just really be, standing up for sex workers and for the trans community, which are really under attack at the moment.
Oh, thank you, Luca. I couldn't agree more. And Cindra there has also reminded us that decriminalization is HIV prevention, a good take home there for all of us. So if you are an HIV organization and you are not yet educated about or involved in the decriminalization of sex work, I do strongly urge you to start getting involved and to educate yourselves and your organizations about why some of the current narratives are so dangerous to the health and well-being of ourselves and of key populations. So Anne, or Marge, as you've been called in the chat, which I thought was hilarious, that little hiccup there. So Anne, I was really struck by your bathroom cabinet and your bathroom cabinet story. It really resonated with some people I know and I love. And I see that you've just also put in the chat and some of the challenges on how we get PrEP and PrEP information to African communities, and particularly in Europe. I asked Nikolay to tell us, just now what some of our hints and our top tips might be, and what would, for people who are involved, who are listening in today, who might not yet be doing PrEP education or advocacy with African communities, particularly in Europe, what would your couple of top take-home tips be for what we should be doing next?
Especially for African community, I think it's the information, because a lot of people coming from Africa, they come here with outdated information. People travel. It's not that some of them, it takes them a few, maybe weeks or months for them to get to their destination or to where they are at the moment. And as they travel, they lose time, they lose information, they don't have updated information by the time they get to their place. I always use Maslow hierarchy of needs. All they're looking for is the basics: accommodation, food, and the basics. But as time goes by, then they start, realize, they start making friends and everything, and then they actualize. That's when they start thinking, okay, I need to start looking after myself. I need to start looking after my health. I think the time that it's not that they're traveling from where they're coming from. As they go along, if they're passing through the Mediterranean, there should be information, sharing information until they get to the destination. I just find that it's information dissemination that actually strikes me, that when I'm seeing someone and you're talking to them about PrEP, they go, "What's PrEP? What are you talking about?" They don't know what PrEP is, and then you have to give it information. It's only because of COVID, because PrEP was made free here in Ireland since November 2019, and we were really on a campaign of trying to get PrEP to everyone. And with COVID, we couldn't. We will start all over again, but it will be also beneficial for all the other organizations, NGOs, to share information, to share what they're doing in their own organizations. Thank you.
Thank you, Anne. And I'm really struck again from the work that I've been doing in the UK that so many people who are moving into places like London don't understand that certain health services are available to them, that are available for free. And again, just as a call that we are advocates around supporting decriminalization of sex work, I shout out that all of our HIV advocacy should also be underpinned in support of human rights and the rights of people who are migrating across Europe and into Europe to be supported and have the human rights to access to healthcare, including PrEP. I'm really cognizant that I have 5 minutes to wrap up, but Cindra, you are going to have to be nice and precise. But I do want to hear from you, Cindra. I'm overwhelmed by the amount of pipeline PrEP that's either already going towards phase 3 trial or already embedded in kind of arguments for why these different technologies should be available. From an advocacy perspective, Cindra, where should we start to put where should we centralize our advocacy? And I'm kind of want to do a really quick reflection that for those of us who've worked in this field for so long, a bunch of us spent 5-7 years advocating for microbicides, rectal microbicides, vaginal microbicides. We put so much energy into microbicides, but now we kind of almost don't speak about them. And is there a danger that with so many different technologies in the pipeline, that we're advocating for a technology that by the time we've pushed for it, another technology will come behind it? So for example, we're putting a lot of our advocacy time into pushing for long-acting injectable PrEP and CAB PrEP, which is, you know, so close to being made available. Yet you've also told us that in the pipeline there's an injectable PrEP that I could take for every 6 months, that for me seems much more attractive. So where should we be focusing our advocacy, given this huge menu of potential PrEP that's in the pipeline? Well, and you have 1 minute to answer that.
Will, you always ask the best questions. It's a really great question. So yes, there's all those colors and drugs and everything, and it's great. It's all preclinical, early phase. You know what? As advocates, we don't need to be tracking it so closely. Where we really need to be tracking are these because not all of it's going to make it to phase 3. Not all of it's going to make it to those large scale trials that they have in women in Africa and gay men in the North. Only a few of them are going to make it to these large scale trials because they cost tens of millions of dollars. So paying attention to a drug and a delivery thingy, the next shiny object, once it's really moving along the clinical trial spectrum, and especially when it's in phase 2 and phase 3, because that's where it's showing a lot of promise. And we really need to get in front of it for many years before it actually gets its stamp of approval, before the results come in. And because we lost so much time with oral PrEP and we're still figuring out how to get PrEP to people in Western Europe, oral PrEP, we don't want to make those mistakes. We can learn from those mistakes of oral PrEP, the lag. And cabotegravir is going to be a nice option, not for everyone, but really paying attention to the large scale, that phase of research is important as advocates, because let me just say, the science is easy, and the science goes faster than poverty reduction and stigma reduction and all of those structural barriers. The science moves really fast, and we need to be prepared, better prepared than we've been.
Thank you. Thank you, Cindra. And thank the goddesses for AVAC that help to guide us in where we should be pushing advocacy and producing those really accessible and simple pieces of information that help us to understand what is in the pipeline. I have 60 seconds, and just like Harriet, I want us to make sure that we finish as close to time as possible. So that I don't forget this, in just a moment, Rocco is going to put up a survey that helps to get feedback on today's event. Thank you to all of the speakers who have spent a lot of time planning today's event. Our apologies for those tech hiccups. They do happen. And so all of the organizations that helped put today's event together are here on the bottom. I'm going to really briefly summarize where I think, thank you, Gus, apologies for not getting to your question there. It was great to see you. I'm going to really quickly try to summarize what I think our next steps are. EATG and AVAC are starting to build the foundations of a community manifesto. This community manifesto, we hope, will serve as a basis for our collaborative advocacy to push for PrEP across the whole of Europe and beyond, and to really keep an eye on those new pipeline technologies and think about how we might target and push for them. Our advocacy needs to include pushing for new tools, pushing for pricing of new approved PrEP to make sure that it's affordable for our health services. We need to push for new approval of those drugs and those technologies that are already in the pipeline and are coming out of phase 3 trials. And then we need to push for advocacy for implementation. These are all of the roots of advocacy that we need to be focusing on. We need to think, as Cindra has helped us to do today, to think about where our advocacy should be focused. And as a number of speakers have said, we need to be able to learn from the lessons of oral PrEP. I love this idea that Thijs talked about making sure that we collaborate and think differently from the learnings of oral PrEP about how we might implement some of those new technologies. Thijs also reminded us that as we talk about the implementation of these new technologies, these new novel technologies, we also need to think about the other specialist technologies, including newly sensitive HIV tests that will need to be implemented alongside. This is not just about introducing a new pill or a new injectable or a new vaginal ring. It's about the other technologies that need to sit alongside, and we need to be knowledgeable about them, and we need to be advocating for them. I'm really, really taken by the conversations about making sure that we look about the broader implementations, the human rights issues about implementation of PrEP, and they include, but are not also exhaustive, around advocating for the rights of sex workers, of migrants, for being feminists and advocating for the rights of women and trans people and non-binary people and all of those other people who are currently excluded. We need to be human rights advocates within our HIV prevention. We talked about the role of stigma, and again, I'm really, really taken by Anne's image. I'm going to take that image away with me in my head, the Anne's image of the bathroom cabinet. I love that Eastern Europe is helping to show the rest of Europe and the rest of the world about how we do PrEP implementation. Thank you, folks, for reminding us in Ukraine about the role of the holistic approach, that we, in our PrEP work, we also need to be thinking about mental health, chemsex, and all of those other holistic issues. It's not just about pills. It's not just about a new injection. So I'm 3 minutes over. I'm really sorry, Harriet. You can spank me very hard next time we see each other. Bless you all for coming today. Again, our love and solidarity to those folks in Ukraine. We are really with you. Thank you again for our speakers. I think that's it. Remember to do the survey. Over and out.
Thanks all. Bye. Thanks, EATG. Annalise, thanks.
Bye, everyone. Thank you.
Bye-bye. Thank you.
Bye.
Thank you. Bye.
Thank you.